We're going to shift gears just a little bit, but not a lot actually, because I'm going to sort of rely a lot on what Richard has had to say to you this morning. What I want to do also, though, very quickly is just thank all of you for coming, and I'm hoping that at the end of the day we can give you something new, we can give you something to think about, and for sure, by the end of the day, please make sure you ask us questions if you have questions, okay? Because I'm a prescriber of eculizumab, I'm obligated to tell you that I don't have any particular disclosures, and I won't be talking about it except for using it on label. So the diagnosis, that was the first part of, I sort of have three pieces that I have to address here. The first part is a clinical that it's a clinical diagnosis. That has not changed since the last time that I talked to you. And in fact, the real problem here is there is no confirmatory test that we can use to tell you with 100% certainty that you have atypical aHUS. In the acute setting, if you present to the emergency room, you present to your hospital, we're still stuck, if you will, even today in 2014, even into 2015, I can almost guarantee you we're still using our clinical acumen to decide whether you have atypical aHUS or not. We're often also having to rule out other diseases, and I'm sure there's people in this room that have been in that circumstance. In children, it's not as numerous, the things that we have to rule out, but in adults, for sure, I think the last time I counted, there's about 18 things we have to rule out before we get to atypical aHUS. And those other things, by the way, are more common. You all know this. This is a rare disease. Those other things are not as rare, so of course they get pushed to the top of the list. It is very important to remind all of us that when you, again, present very acutely, the genetics are not key to making the diagnosis before treatment is started. And you probably know now, the efforts are to move towards plasma exchange or, obviously, preferred eculizumab, Soliris, very quickly if you can. You can't wait for the genetics. It's a clinical diagnosis. The decision needs to be made to treat. Why? Because genetic mutations are only positive in about 50 to 70% right now. And I'm going to have a slide in a few minutes that says that just because you don't have a genetic abnormality does not mean that you don't have atypical aHUS. What it means is Richard's team needs to work harder, right? But it is important because we don't want that to confuse the issue. Number one, we don't want treatment to delay until genetics are available to you, and we don't want you to not be treated appropriately if your genetics are negative. Now, I'm going to bring up the reasons why genetics are incredibly important in this disease. Many of you already know that, but I'm going to bring up some reasons why it is important. It's just at the time of diagnosis, in the first 48 hours or whatever it takes to make your diagnosis, they're not as important. So here's my cartoon for how this works, and Richard's already begun the discussion with you, and I wanted to give you an idea of what the three most important things are when we talk about someone with a diagnosis of atypical aHUS. The first thing we have, obviously, are the group of patients who have what we call a microangiopathic hemolytic anemia. And what that should mean to you is that if we say microangiopathic, what we essentially mean is that you have schistocytes in your blood. You may have heard that term before, but in fact, what they are pieces of red blood cells. And when those pieces become pieces, they release, or they're hemolyzed, if you will, or they release a contents we call LDH. So LDH is elevated, schistocytes are present, and then finally you have anemia. So your blood count is low, and that's often represented by a low hemoglobin. The next thing we have, and I should point out, I don't know if you can see on that picture, you have these little guys called platelets, little purple sort of very rough looking things. What happens if you have atypical aHUS is you get a very low platelet count, so a number of those disappear. That's your risk for bleeding or having by the way, where did those platelets go? They go into the blood clot. So that's where they're disappearing to. Together, those two items make up what we call a thrombotic microangiopathy. So those are the two pieces that make up the thrombotic microangiopathy. If you then add the renal failure, that's when you get the aHUS or you get the atypical aHUS. So it is a microangiopathic hemolytic anemia with thrombocytopenia and then also with renal failure. The reason it's a little bit important to go through that, many of you know that. If you've watched your labs, you know these are the sorts of things we're looking for. Here's the problem. What is the best way to tell if you have atypical aHUS? I'm going to give you a preview. It's not if you have a TMA with renal failure. Unfortunately, I sort of gave you the presentation that said that we don't have that one lab. So what we do is we make some assumptions, we make some clinical decisions. But the first thing, again, we won't get hung up on the genetics. Having a genetic mutation does not mean that you have atypical aHUS. Why? Does anybody know why?
It doesn't express itself.
Exactly. We have moms and dads in this room with the same genetic abnormality that their child has, but they do not have atypical aHUS. Again, Richard's team needs to get to work on that, right? Similarly, we also have families in this room who do not have a genetic mutation. That does not mean that they don't have a perfect clinical case of atypical aHUS. So what is the best evidence? I sort of highlighted the word recurrent there because obviously none of you want to be in that circumstance, but the best evidence is for you to have another episode. That's the only time we're really sure that that's what you have. We're obviously attempting not to put you in that situation, so what we like to try to find, of course, after the fact, after you present with your first episode, are the genetic abnormalities that have functional significance. We know from the work that's being done in the laboratory that those genes are doing something wrong, and they're doing something wrong to the complement system, and maybe, as Richard has already given you a preview to in the future, maybe they're doing something wrong to the coagulation system. So that's the best way you know that you have atypical aHUS. But again, many of us don't have that when we show up. Finally, you have to be able to rule out, especially in the adults, it's a little less important in the children, but it's still in some cases, you have to be able to rule out that there aren't other things going on. Well, I told you, there are some other things going on. This is my cartoon for that. Every single one of these, and the last time I showed this, those of you who were here 2 years ago know that it was a lot of alphabet soup up there. I've tried to replace it with some of the newer things that are going on, but you can see every single one of those, even pregnancy, can cause the same thing that's going on with atypical aHUS. The difference is that, if you'll notice, I got rid of TTP and I got rid of this one we call STHUS, which is Shiga toxin-associated aHUS. That's the one that you get from eating bad hamburger or unpasteurized cider, those sorts of things. We can now get rid of those two. But how do we get to atypical aHUS? It's very difficult. We still have to rule out a lot of those other things. And we don't need to dwell on that here because we're going to get to some more interesting things, I think, for the audience. But suffice it to say, I've presented you, just because I understand you will get copies of this, I've presented to you the list of things that your physician has to go through in order to try to, again, put you back in that atypical aHUS box. Again, these diseases are much more common than the atypical aHUS, so we do have to go through all of them. And I'm sure very many of you have gone through this testing. The reason it's important, and I'm being a little bit cavalier here, but I wanted to show you some examples. I have several cases here. 7-year-old who has a TMA, I showed you what a TMA looks like, and now they have renal failure, so that's their aHUS. 7-year-old with a TMA aHUS receiving chemotherapy. 48-year-old with very high blood pressure who just wasn't taking their medicine because they couldn't get it filled. 6-week-old with a TMA and aHUS. A 9-year-old with a TMA and aHUS with severe gallstone pancreatitis. A 33-year-old with TMA and aHUS after stem cell transplant. An 11-year-old with TMA aHUS and has lost native kidney and 1 transplant. A 21-year-old with TMA aHUS, butterfly rash, joints that hurt, things are swelling. And finally, a 3-year-old with TMA aHUS after that unpasteurized cider. I wanted to just present these to you. We don't have to go over them in great detail, but I'm going to get back to them. How many of these do you think are atypical aHUS? That's where I'm going with this. This is what your clinician has been sort of faced with, trying to weed through this and figure out what's going on. So what do we do when we do therapy? Richard's already sort of given you an idea that we focus with the complement system. We focus at the complement system, and that makes the most sense pathologically. Historically, and it's worth definitely mentioning here because there will have been people in this room that have been exposed to plasma therapy. We're working with one family that actually did very well with plasma therapy. It is potentially useful in a certain group of patients. And so the problem with plasma therapy is that it's not been well studied. We haven't had our prospective, we would love randomized control. We haven't had the trials that we need to tell us whether plasma therapy will work. Having said that, we go back and we look in the literature and we find out who has responded. And in this case, I've just drawn out one of the studies because I'm trying to keep the discussion sort of a little bit limited here. I have one study where we've got a hematologic remission, and what that means is the anemia improves, the schistocytes go away, the platelets go to normal. They had 5% or a 90% response. That's probably not very useful if you're the 5% responder. It depended on what the genetic mutation was, frankly, in that study. Similarly, you could get a hematologic remission but not get a kidney remission or a kidney response. And so the kidney responses in that study were 3 to 75%. And I've put the reference there so that you can look it up if you'd like. But the point is that not only have we not studied plasma therapy the way we need to really know for sure which one of you it may work for, but we also recognize that even in some of the genetic mutations, some of the abnormalities, it frankly won't be very useful for you. Why must it remain on our list? I'm a practicing nephrologist. It has to remain on my list of things to use. Why? Because we have complement factor H autoantibodies, so it's that Y that he talked about a few moments ago. In theory, you remove that Y, and that patient will go into remission and potentially not need eculizumab long term or plasma exchange long term. We also obviously have places in the world that cannot get eculizumab. It's not even allowed in some countries. We also have the situation where either the hospital can't pay for eculizumab or it can't be gotten into the hospital, or even I unfortunately also have one patient who has met his lifetime cap for his copay. Or that's not the right way to say it. I should say he's basically met his max for what he can tolerate pain based on what he's been exposed to with his eculizumab doses. And finally, there's clinician experience. Many clinicians will be very much more comfortable being able to just trigger the use of plasma exchange, and we do appreciate that because of what Dr. Smith has said before. In the adult world, part of that differential is figuring out whether you have TTP. If you have TTP, you have to begin plasma exchange, and you should do it immediately. And that is very appropriate treatment for TTP. So there are clearly circumstances where plasma exchange needs to remain in our armamentarium. I also have to bring up liver transplant. You may or may not know this is a relatively, like Bill was saying, we're somewhat of a new group here. We have newer patients here. Liver transplant sounds very odd, but in fact, if you have a complement protein that is made by the liver and it is not functioning well, if you give a new liver, you can potentially make that patient make appropriate normal protein, and in theory, it's curative. So that is an option for you. So the requirements are, frankly, that it has to be liver-derived, so the liver has to be making this particular protein. It must be the only thing that's wrong. It also must be, one of the things that's being used right now is plasma intolerance. So for instance, if you had been getting plasma and it wasn't working for you, that might be another reason to consider the liver. If you have a patient or physician preference for this, all of us are pretty autonomous in our decision making, right? So there may be patient-physician preference for this. And again, I'm thinking about in the circumstances where perhaps eculizumab isn't available or for some reason it's not being used. So these are reasons, or that patient-physician preference may in fact end up being that they don't want to stay on eculizumab for a lifetime, for instance. And then finally, obviously, the last statement being that when eculizumab is not available. So I do want you to remember that we do consider plasma therapy. We actually do use it in the adult world, probably more than the pediatric world. It needs to stay on our list of things to do. Liver transplant needs to stay on our list of things to do. However, as Richard has already sort of talked about, atypical aHUS treatment was obviously revolutionized as soon as we had eculizumab available to us. And it occurred to me that Richard didn't mention, and I didn't include in my slide, how eculizumab might work for you, but you'll remember the pathway where you get to the point where C5 begins the process of making C5, C6, C7, etc., and then you can poke the hole in the cell, whether it's self or bacteria. Eculizumab blocks C5 so that it cannot proceed on to the rest of the pathway. So that's why eculizumab works, and it does an absolutely excellent job. I've given you the reference. I won't spend a lot of time on eculizumab except to say that it's a wonderful drug, that patients get not only hematologic remission, but they also get renal improvement. Not only stabilization of the initial renal function, patients can actually get an improvement in what we call their estimated GFR, or an improvement in their ability to clear their blood. They can also come off of dialysis. So I would encourage you, if you want to know the details of that, to refer to that manuscript. And if we need to, Amy I can make sure that that manuscript shows up on your CDs if you would prefer for that. I understand we're very near to getting the 2-year data on the prospective trials too, so we'll have a sense of how patients are doing 2 years out. The reason I'm not spending a ton of time on these particular things, oh, I forgot to mention. So this is what it looks like here at Iowa. And again, you know, I should have prefaced this, and I think Richard said a little bit about this. This is how we practice. It doesn't mean how every physician practices, but this is a general idea of how it might go. If you had an adult who presented in the emergency room with a TMA, with aHUS, so what is believed to be possibly atypical aHUS, the first thing we want to do is rule out alternative diseases. And we do that by, we order that test that Richard was talking about, an Adams TS13. After that test has been drawn and goes off, we start plasma exchange. Why do we start plasma exchange in the day of eculizumab? Because if they do have TTP, eculizumab is the wrong choice of drug. It won't work. So we start the plasma exchange, we get our Adams TS13 back, usually within 48 hours, 72 hours. If it's normal or not less than 10%, the number that he offered to you a few minutes ago, we flip them over to eculizumab. Okay? If they've had an episode previously and we already know it's not TTP, we skip the plasma exchange. We go directly to Soliris. For the children, it's a little bit different. We still send the Adams TS13. We rule out Shiga toxin aHUS, which in theory, again, that's a great clinical diagnosis too, because very many of those kids have an exposure, they have bloody diarrhea. There's lots of reasons to think that we might be dealing with a Shiga toxin aHUS, but we rule out both of those. We rule out anything else if they have an unusual picture. If that's the butterfly rash, the joints that hurt, things that are swelling, we're thinking about another disease. We're not necessarily thinking about atypical aHUS. We try to rule that out. But nonetheless, even before we get the answers to all of our tests, we're already moving towards Soliris in a child. Very quickly, we want them started. And again, the concept is the sooner we start, the more likely we're going to get a remission, the more likely we're going to have kidney improvement or kidney stability over the longer term. And then, of course, it's with respect to complement factor H autoantibody, we may, in fact, want to consider giving the patient anticellular therapy. And that might be a little bit counterintuitive to you, but what we're trying to do is get rid of the cell that's making the antibody, because if we can get rid of the antibody, similar to what we were doing with the plasma exchange, if we can get rid of the antibody, keep the antibody away, in theory, those patients are cured. In theory, they would not need long-term Soliris. So that would be the reason why we would consider anticellular therapy in that setting. And then finally, if a child shows up with a second case, for instance, this is a child who's out there right now who is not on Soliris, is not having difficulty with episodes, and they present to the emergency department now, in theory, at many institutions, but for sure for ours, they would be started on Soliris immediately without, you know, the sort of the haggling about whether we needed to do plasma exchange or not. So this was, it's my job, I think, I don't think Richard mentioned this to you. Before this meeting, we solicited questions, and we had I think Amy could probably confirm for sure, but I think we had 42 questions, something like that, 42 questions that came from either the people that are here or other questions. And I'm only listing 13 of them because those were the 13 I got taxed with. So Richard interspersed those in his, and we've made sure that everyone is addressing the questions as much as possible. So they've been folded into the lectures. I wanted to show you this because this is what I wanted to spend more time on. This is what you were asking about. You weren't asking me about treatment actually this year, which was so different, or about the initial treatment, the use of Solaris, etc. You weren't asking me about that like you were 2 years ago. You know, should I use Solaris? How should I use Solaris? It wasn't that so much. Now it's this, and so take a look at some of those questions. We would like to learn about remission and if it's possible to eventually come off of Solaris. Recommendations from doctors regarding Solaris long-term use. Is there a possibility of needing fewer doses over the years? Is there a possibility that we can in fact spread the doses out? You can see that those are the questions that are being asked. And I wanted to give my disclaimer. I didn't have to give you one for eculizumab, but I'll give you one right now. This is an incredibly difficult topic for most physicians right now. We don't know the answer to this. And I will give you, an offline statement, which isn't very offline because I'm being taped. Iowa, in general, believes that once you go on Solaris, you stay on Solaris. We don't feel that the data is good enough to take you off right now. Now, I said in general, so that's the first thing. The second thing, have we thought about a cessation plan? Have we thought about a stopping plan? Absolutely, we've thought about it, and we're still, to this day, going through all the iterations, trying to figure out how we could do it if it turns out that the world literature suddenly becomes better tomorrow, and we need to make a plan for our kids or for our adults. We have absolutely thought about it, but it's a very difficult discussion, and I don't want to trap you guys between me and your physician and what's going on. What I would just like you to know is what data is out there and what sorts of things are being talked about, because it was a very specific question that's being brought up to us. That's in the slides. No one knows, okay? What we do know is that patients get kidney loss if they have yet another episode. And again, I'm not even talking about if a patient has extra-renal symptoms, and by that I mean they've had some neurologic dysfunction or they've had lots of gastrointestinal dysfunction issues. We know that if their constellation was kidney disease and central nervous system disease, that potentially being off Solaris is a problem for them. So we keep that constantly in the back of our minds as we're dealing with this. So what does it mean to utilize non-label dosing? That was one of the questions. That was, if I paraphrase, that was a number of the questions that were being asked. It means basically using either a smaller or larger dose, avoiding booster doses after plasma therapy. Any of you that have gotten plasma therapy know that the package insert says you give additional dosing after plasma therapy, okay? Or extending the dose interval. I should have added on there using non-labeled, it's not on the label, lifetime therapy, but technically, taking someone off when it's considered that maybe patients should remain on could be considered. It's not on the label, but it could be considered dosing in a different pattern, if you will. There's the label. I'm going to zero in on the bottom, on this very bottom part, just so that you know what actually label dosing is. You can see that if you're an adult, this is the dosing that you use, and if we're in the pediatric realm, that's the dosing that we use. So that's what's classified as standard dosing. In general, people should be on every 2 weeks, and it should be, for the average adult, at roughly 1,200 milligrams. In the child, it's after they get to a certain phase, it's also every 2 weeks, and then it's based on body weight. Essentially, we bump the dose up periodically. Why are you even asking the question? You know why you're asking the question. I will tell you what the physician's impression about why you might be asking the question. The first one is that from a physician standpoint, we're accustomed to limiting exposures. We're accustomed to reducing your exposure, the patient's exposure to drugs, when we worry about whether there is long-term side effects. We don't know. We need more time with complement blockade To be completely honest, we don't believe there are long-term side effects, but I am sure you will find physicians out there who wonder about that. Physicians concerned for long-term risk for meningococcus. You know that when we immunize you currently in the United States, we can only immunize you against 60% of meningococcus. We don't have a vaccine yet here in the United States, readily available to you anyway, that will cover the other 40%. I would like to say that one's coming. We'll see it fairly soon, I understand. But in the meantime, we have to worry about your exposure to meningococcus. We lack the scientific evidence to know whether your disease is active, not active, if you're inactive now, what's going to happen next, when will you become active. We lack all of the scientific information we need about that to know exactly how to treat you, and that's, can be pretty uncomfortable for us. And then this last one has actually been put to me more than once from my own patient group is this desire to not have to get every 2-week IV dosing. If you have a port, not wanting to get your port accessed every 2 weeks, that sort of thing. So, and for sure, we can minimize very many of these pieces by sort of a rebuttal, if you will. I'm just giving you what's been said and what's been considered when we're thinking about how this should go. So I already gave you the Iowa caveat. We in general would prefer that patients stay on dosing unless there are circumstances, which of course we discuss with families, one-on-one. But who should I put it in parentheses, but who should probably not come off of dosing? Even in the perfect world, and again, we're not at dose changing, but patients with multiple episodes, that would, in my mind, be a bad idea. Anyone who's had multiple episodes, because every time you have an episode, you are going to damage kidney. Patients who have family members who've gone to end-stage renal disease based on their atypical aHUS. Patients who have cardiac or central nervous system involvement. If you've ever known a child or known of someone who has had a stroke because of their atypical aHUS, that's not the patient population that you want to be experimenting on, if you will, by altering doses. If you have a patient who has suffered only one episode, but with that one episode has suffered a very substantial kidney injury, that is also not a patient population that you want to be making a decision about whether they could space their doses out or come off of drug or anything like that. So these are, and finally, patients on a transplant are probably the golden rule right now. Obviously that's not to say that people still have their own kidneys, don't get the same impression from their medical caregivers, but to my mind, there's no one that's even thinking about taking transplant patients off right now. So, and again, that's outside of Iowa, but there may be certain mutations, and again, this gets back to Richard and his lab, there may be certain mutations where we shouldn't be taking patients off because the risk is high that we actually may trigger an episode. And so what I want to do is give you the evidence. So what is the evidence that patients could have spaced out doses? We have no idea. There isn't any evidence. What is the evidence that patients could come off? We have these 22 patients. I will admit freely that 2 of them are mine, but 20 of them are published in the literature. Age range 1 to 53. They're followed over 5 to 25 months, so the shortest follow-up was only 5 months. There were 4 relapses out of those 22 patients. Mutations included both CFH, MCP, C3, no mutation, and then CFH autoantibodies. So, and again, I can provide the references for each one of these, but what I really wanted to do is narrow down very quickly to Dr. Artesino's work, who is a gentleman from Italy who one of our colleagues worked with prior to coming to join us. And I give you this one only because it gives you a sort of a picture, and it gets, pictures make it a little clearer for us. His study was where he actually took 10 patients off of drug. When he took 10 patients off of drug, 3 of 10 of those actually relapsed. Each of the relapsers had a complement factor H abnormality, and I say abnormality in quotation marks because they either had a complement factor H mutation or they had a complement factor H autoantibody that was of relatively high titer. Relapse occurred in 3 patients, and all 3 patients within 2 months, so it was fairly quick. The range in follow-up for this particular group was 6 months to 23 months. Why is that important to mention? I often will use the case, and she's not here. If she was here, she wouldn't mind me saying this. I often use the case of my patient who waited 8 years to have her first episode. She waited 2.5 years to have her second episode. This was pre-eculizumab. In both cases, she presented to the emergency room with a kidney that no longer worked. So short follow-up times right now in the literature are, make physicians a little bit nervous. We want to know that, people are able to do without medications for a longer period of time before we would be more comfortable that everything would be going okay for them. So let me go back to the list. You be the clinician. Of those patients that I gave you, only 3 of them had atypical aHUS. The point is your physicians have their work cut out for you trying to, not this group, so we have this group sort of contained, under control, if you will, or sort of have a good idea what's going on. But you can see that when other patients present, this is what the physicians are having to deal with, and it makes it very hard for them. But every day we move forward. This is a model that how what I expect in the next years, not today, not tomorrow. This is an idea. I mean, number of the people in the group asked me to speculate what this would look like if it could be done. It can't be done right now, but if it were going to be done, this might be what it would look like. And what I would say is that there is a certain, with all of these, you could separate patients out by what their genetic mutations were potentially. And it could very well be that if you have a certain group of mutations, like we already talked about, you should never come off drug. It's an excellent drug. We need to be using it to keep your kidney happy. We need to be using it to keep your heart, your brain, all of that stuff happy. We have no idea what to do with MCB mutations because they're pretty difficult. In adults, they relapse, and when they relapse, they actually go to end stage. In kids, they may relapse again and again and again and again, and each time they relapse, they may actually lose a little bit of kidney function. So I don't think we have any idea what we should do about MCP mutations. If you have an alternative disease, and I bring this up because this is real life, even in my hospital, we may have started you on Solaris and then really understood that after all the dust settles that you didn't have atypical aHUS. I have no doubt that the Solaris has been beneficial to this patient with TMA, but they probably don't need to, or I should say they don't need to stay on drug for a lifetime because their disease truly wasn't what you have. It was a different disease. And in fact, that's been my experience in patients that I've taken them off. That has been the only time I've taken them off. And then the last one is the most controversial is the issue about what if you don't have any complement mutations, or if you're on dialysis already. If you've already made it to dialysis and you're not getting off, then how long do we treat you? We don't know. We honestly don't know. I know that some of the physicians are talking about whether it could be a possibility of treating for a year, 3 years in kids, something, there'll be some time frame. And, I wrote down 1 year, but I think that we don't really even know what that will look like in the future. So finally, for the new horizons, based on everything I've said, based on what Richard has had to say, we want to, first of all, identify better biomarkers. So can we tell whether you have atypical aHUS when you pop into the emergency room? That would be great if we could do that. Could we tell whether when you're getting a routine follow-up, whether you have or you have an impending atypical aHUS exacerbation? Those would be excellent biomarkers to have available to us. Can we uncover the genetic background of those that are affected, meaning they actually have the clinical syndrome of atypical aHUS, as opposed to their dad or grandma or someone in their family that has the same genetic mutation but's not affected? Is there something about their genetic background that is protective? It could be, and that's what we need to know. Can we establish the cause or etiology of the other TMAs? Of course. What we do now is we assume that everything is atypical aHUS, we treat, and then we try to figure out whether in fact they're not. We need to know how much complement is involved in all these other diseases, and that's something that's going to be very important for us to learn. Finally, what we would know after deciding what the background cause is, what the etiology is, what protein is not working, is it the coagulation system that's primary or is it the complement system that's primary, we would be better equipped to choose medications to treat. Obviously, eculizumab is fantastic because where does it block? It blocks at the very distal part of the pathway. And I'll just use this as an example, but if factor H were the problem and you had a factor H blocker, it would probably make more sense to use that. Then you might not have the same side effects or the same long-term concerns about being on a distal complement blockade. Those are just examples. And again, I deliberately didn't present a lot about what's going on in therapy because there isn't anything immediately available to you in the pipeline. There are a couple of drugs we call a mini factor H. There's one called Compstatin. There are, there's even, I don't know if any of you know what small RNA, there's lots of different possibilities of what might be coming up in the very, very near future, but what we really need to know is what the background cause of disease is. I only have one more slide for you because you guys had 14 questions for me and I wanted to throw back at you. We just had a meeting relatively recently of a number of atypical aHUS, physicians who deal a lot with atypical aHUS, and here's our 14 questions. We absolutely have questions just like you do about what the future, what we need to solve, what are the answers we need in the near future. And we really did try to tackle this particular list of questions just recently, and I hope within the next 6 months you'll actually see a publication come out that will address a number of these. And they will be recommendations. They possibly will be light on evidence because, as you know, as Bill pointed out in the very beginning, we're still trying very hard to create the evidence we need to make all the decisions we need to make in this set of diseases. But this is our list of questions. Hopefully we're also working on yours at the same time. Thank you.